Okay, you all, this next guest is basically the greatest of all time when it comes to airway dentistry. You know him as Dr. Jeff Rouse. I was nervous. I'm not going to lie. This was so cool to be able to interview Dr. Rouse for Jaw Talk, and you're not going to want to miss this episode. So, Dr. Jeff Rouse is a distinguished airway prosthodontist with a passion for unearthing all of his wisdom and being a mentor for all of you dentists who want to journey into the world of airway dentistry. Dr. Rouse maintains a full-time private practice. He's a clinical adjunct associate professor in the Department of Prosthodontics at the University of Texas Health Science Center in San Antonio. After graduation from dental school in San Antonio, Dr. Rouse completed a 2-year general practice residency at the University of Connecticut Health Science Center. He practiced family dentistry for 12 years before returning to school. Dr. Rouse received his specialty certificate in prosthodontics from the University of Texas Health Science Center in San Antonio in 2004. Stay tuned for a conversation with Dr. Jeff Rouse as he takes us on a journey of relentless curiosity, challenging the status quo and redefining the boundaries of dental knowledge. Let's dive right in. Quick legal disclaimer. All information in this podcast is the opinion of the speakers and not meant to be a substitute for a diagnosis and consultation of a qualified healthcare provider. Welcome to Jaw Talk. I am so excited today. We have someone who is a legend, and I am so excited to have Dr. Jeff Rouse on the show. Thank you so much, Dr. Jeff Rouse. I've looked up to you as far as like spear education. You know, I'm in kind of the greater Seattle, Tacoma area. So we just have all of these, amazing dental educators, and you're one of them. So thank you so much for being on my podcast today.
Oh, thanks, Tiffany. As I was telling you, I follow your work, and I'm very impressed with everything you've done and how quickly you're doing it. We have a lot of common friends, not only friends, but also people that I got a chance to work with, because I was up with Greg Kinzer for a couple of years in Seattle working there, developing a lot of the airway material while I was there. And so what an incredible dental community up there. And I'm trying my best to bring it back to San Antonio. So we're working hard to get the same sort of quality here as well.
Yeah, well, if you're still in triple digits of heat, you may want to consider Seattle because we're just soaking it up right now.
No, this is a perfect time to be there. You're right. I don't know of anywhere in the world that's as good in August. So
I know,
you
I
beat
know.
us
I
there.
mean, I'm looking out my window at Mount Rainier and the Sound right now, and it's just, for us to hit 90 is, we're all kind of like sweating and swearing because nobody has air conditioning.
I know I was there one time. It was 95. It's brutal. It's way worse than San Antonio at 100.
Okay, yeah, I know. You just feel like the sun's gonna kill you.
Yeah.
Yeah,
So
yeah. Well, tell us a little bit about who you are, what you're passionate about, the airway side of things. You're an airway prosthodontist. Obviously, your bio is so impressive, all of the work that you've done. But tell us, how did you personally get into, looking at sleep and airway management and kind of bringing that into your dental practice?
So, I guess the story starts a long time ago because I've always been rather passionate about finding answers. And so I was a general dentist, a family dentist actually, for 14 years. And during that period of time, I lectured some. Mostly, I did a lot of work with implant companies. I did some designs on implant pieces and parts and prosthetic designs, and then started working with Bill Robbins. And Bill and I developed this global diagnosis idea of how to sort of build off of what Frank Spear and John Coyce had developed as far as facially generated treatment planning. And in that period of time, I made a decision that I wanted to find more answers and be the best I could be at what I was really good at, which was pros. So I did general dentistry while going back to a prosthodontic residency. So I split time. It took me 4 years to do that, but I finished and then became a prosthodontist. Part of that reasoning or logic for me was I wanted to dive deeper into answers. Like occlusion didn't make sense to me. Like the way we were teaching it, why things were happening the way they were didn't make sense to me. And sure enough, when I got the time to slow down and read the literature, I realized that our literature in the world of occlusion is horrid. I mean, it's not even, it was like it would have been better had we had a shaman around a campfire telling us stories of old, because that really was what it was about. There was no scientific basis for the things that we were doing or saying. And what scientific basis that we would claim was there, we were actually, in many times, just lying. I mean, it didn't even say it when we went back and read it. So it was crazy how many things that I was taught were gospel were really not true at all, and they were just lore. And so that got me onto a journey and an interest in the world of bruxism. I really wanted to focus in and figure that one out, because I figured if I could really read the literature and really figure it out in a way that no one else had, that maybe we'd have a chance to develop an occlusal scheme that actually could assist people in not breaking things and not hurting themselves. And so this journey of bruxism began about 2004, and by 2007 or 8, I had started to get into the literature that dealt with airway, or at the time it was apnea, and bruxism, and an interrelationship between those two. And so it sort of built off that. And by 2010, I had written an article called The Bruxism Triad, which was about bruxism and its relationship to airway issues and reflux issues, and how those things seem to all be related to one another and feed off of each other, and then kept going from there. So that's kind of where it began and how it began, but it really is rooted in the fact that I never accepted, after that sort of beginning journey in pros, I never accepted what I had been taught. I ended up saying, well, wait a second, let me read the literature and see if this really comes true. And by the way, that I get in a lot of battles with orthodontists in particular, interestingly, and they say, well, the orthodontic literature doesn't support this, that, and the other. I'm like, yeah, go read where your base of knowledge came from, and then come back and talk to me about the new literature that's out there, because the old stuff is just like what I read in pros. It's just awful. And so a lot of our concepts are actually misconceptions of what the reality of the world is. It's just that that's what we were taught in school, therefore it has to be true. Or that's what we were taught by a really famous guy, and therefore it has to be true.
Right.
So that's where it all kind of began. I'm too competitive, or I don't know how to say it. I don't know what the proper word would be. I'm too stupid maybe to accept and just move along. I keep going, why, and the answers I
No,
was
I
getting
think
were bad.
that's what drives us forward, right? Is to sometimes like look from our mistakes. Maybe you did these beautiful veneers, but then the patients fractured them, or it's like broken restorations. And I think you had mentioned in a previous podcast with Dr. Melissa Seibert is, as dentists, we're very mechanical. We want to fix things with a burr. And, so when there's, kind of like you said, biological reasons, like maybe, airway issues, or maybe TM joint breakdown, or, musculoskeletal factors that are part of the picture, we want to just jump to treatment and not necessarily sit there and, spend the time up front to establish that diagnosis and kind of that bigger lens of our patients.
Yeah, it sounds like something I would have said. Yeah,
Oh,
yeah,
good,
exactly.
good.
Yeah. No,
Well,
the,
I mean,
the the biology of the system is commonly ignored. I mean, we've been very mechanical, especially in my world and in the world of prop. I mean, it has always been rooted in a mechanical. How do you make a denture on an articulator? And that's where it all came from and developed from. So our occlusal concepts were, how do I get somebody that has no teeth, no points of reference, and figure out a way not only to make it look good, but also as their jaw moves to make it not get knocked around so much that they can't keep it in their mouth. And then we took that to teeth, but we never, I mean, we just kept making these silly assumptions along the way just because we wanted it to fit this mechanical concept of how teeth interdigitate, rather than considering the biology of the system, which is, as you said, I mean, the joint is probably one of the most commonly ignored factors involved in chewing pathways and tooth wear issues. And I would argue that the maxilla is probably the most ignored because we've never done anything with the maxilla. We've always just made a cast of it, put it on a face bow if we're lucky, got it to the articulator, and then said, okay, now how do we work with the mandible past that?
Or
So,
pushed it back with headgear. That's what
yeah,
I had.
exactly.
I had
That was,
retractive ortho. My dad was a dentist, so.
yeah. Oh,
And
well,
then he
thanks.
said to me, Tiff, you don't want to work with TMJ, TMD patients. They're crazy. And I'm like, no, Dad. When we start to put together modern imaging, CBCT, MRI of the TM joints, we start to put together a comprehensive diagnosis. We start to look at these bigger systemic issues. And it's like, no, they're not crazy. And, you can't ignore the joints. I mean, I've had patients who, I was thinking one patient where I think she had 60 equilibrations. She was a former hygienist, and her joints looked like, I mean, I call it like a high heeled shoe, like a little Louboutin or like a Valentino high heel. Cause like you see the pano and it looks like a little bird beak, and you think about the force distribution on those joints. And, I think for some people at that point, it's just like, well, are you going to do, orthodontic surgery? Are you going to do joint replacement surgery? I tend to be, kind of coming from the conservative care. But for me, probably like you and your workflow, I don't get a lot of young patients. I have patients that are in pain, their joints are breaking down, they've tried a lot of other things. And my whole thing is like, now with interceptive ortho, what if we had kind of that crystal ball to like see that patient, as a 12-year-old? I had Dr. Becca Bacow on, her episode just dropped today. And, the work that she's doing is just so fantastic as far as, being able to see the scaffolding, right, of the musculoskeletal system and evaluate that first before we decide where we're going to put the teeth.
I simplify, or I hopefully simplify the idea, which is you have to get the wax rim developed before you ever put the teeth in the denture.
Oh
And
man, you're
we've,
giving
we've
me like,
all,
I'm starting to sweat thinking about pro.
I was, I was just wondering about your examples for your joints, though. I mean, like Louboutin. Oh, really? There's red on your pano somewhere.
Yeah. Well, and like a healthy one would be like the ice cream cone shape, because it's like the condyle hasn't broken down yet. So,
Yeah, I
you
get to
got to
see a
make it
lot of
your
those. Jim McKee and I have been friends since like '95, so we've been in his. I've been in his house yelling back and forth for entire weekends about which one's more important, the airway or the joint. So
Yeah. Yeah.
we we go over
Well,
and
you
over.
guys have a joint lecture that you've given. Are we treating the same patient? I believe.
Yep, we do.
Yeah.
We
Yeah.
did that at the Equilibration Society, and then we do it at Spear as well. So
Love it. Love it. It's so good. Yeah. Dr. Jim McKee has been such a mentor to me. He was just always so generous with his information. I heard him and Dr. Mark Piper back in 2012 at the California Dental Association. And it was like, finally, someone's talking about this from an orthopedic perspective. In dental school, I felt like we just got hammered with occlusion, and it just didn't ever really make sense to me because we got like 2 days of rotating, with the TMJ oral medicine person, and everyone was like, oh, this is so boring. I just can't wait to get back to the clinic. I just want to work on teeth.
well, at least you got occlusion. I mean, that's one of the things that now when I'm teaching at Spear, the it's interesting. The Spear and places like that used to be, I'm going to go work for 15 years. I'm going to get my practice up to where I want it, and then I'm going to go there, and that's going to be my sort of exit strategy. I'm going to start doing the cases that are more challenging, and then I'll have someone else do the other stuff. And now it's not the case at all. The people that go to Spear, they're going right out of school, and a lot of different reasons probably for that. Maybe COVID and a lack of patients during that moment, brings some insecurity where they want someone to guide them at the beginning. But the huge advantage is they're starting on the right path right away. But what I've found is that their knowledge base of something that was sort of drilled into us and in school, whether well done or not, was occlusion, and it's ignored. I mean, in San Antonio, we don't really have an occlusion course anymore. They just sort of pick it up along the way as they work through different, okay, in dentures, we're going to learn about occlusion here, and in a TMJ course, we're going to learn. I mean, so the background is a lot different than what you came out with, and certainly what I did, because mine was extremely mechanical, but heavily
Yeah.
occlusively based. So
Why are there like so many TMJ camps that all seem like they're fighting with each other? Give us some spicy details. I just don't get it.
uh,
I mean, we can
what
always edit this out if you don't want to.
so the difference between what oral facial pain people and Piper McKee, and so I once again I had a really huge battle one time at the oral facial pain meeting, and it was over bruxism and what triggers it, and I keep waiting. The longer I go out and the more research that supports what I actually was saying that day, the more I'm waiting for letters of apology from the people that we yelled at each other. I think a lot of it, honestly, is that you treat different people. I think oral facial pain people are really dealing with true neuralgia types of things. They're dealing with the unicorn in the room, and you're dealing, your unicorn is more of a horse. I mean, there are a fair number of what you're dealing with. There are very few of what they're dealing with, and then I still believe that there's a muscular, a straight up myofascial type of muscle,
Component.
whatever, like your PT training would
Dystonia. Yeah,
suggest. Those
for
those
sure.
types of patients. I think there's a fair number of them as well. Now, Jim may say that no, it's all, but I think that they're just different groups, and you're all seeing the world from your own perspective, and those perspectives don't jive with one another, and so unless you and that's the reason why the research diagnostic criteria were developed, to try to give people a common language of discussion. But even though we did that, and they've refined it since that point in time, I think when you get in groups, you don't start with, here's the people we're talking about. We're only talking about these people. We're not talking about anybody else. We're talking about these people. And if you were to do that, then you'd have more in common. The other thing that is still unanswered in my mind is that I believe that there is a natural developmental disc displacement patient as opposed to a traumatic disc displacement patient. I was watching Wimbledon recently, and I texted a friend, a guy you know as well, and I texted him and I said, a lot of those people in England fell on their chin when they were young, apparently, because there's a lot of class 2 deep bites there. And I mean, there's got to be just a natural developmental component to it, which is, if the max, in my, seeing it from my world, if the maxilla doesn't develop, the mandible's got to do something. And if the something it does is, I'm going to stay underneath the maxilla, how does it decrease its ramus length naturally? Because if you keep the disc under the condyle, it will grow. And so every time they eat food, it's going to grow. Well, it can't grow. If it grows, it doesn't work. So the body's got to make an adjustment to not grow. And so I don't think every one of those people fell on their chin and suffered some trauma. And I also believe that you can get unilateral problems because you get problems in one hip and you don't get it in the other. I only have to replace my right hip because it degenerated. Why? I don't know. It just did. And it's the
Well, is
same.
it about your gait or body
Any,
mechanics or
anything, or it could just be when they monitor joints of, in particular, because my interest in airway, when they monitor joints of airway patients, there's inflammation in the joints that's unique to the joints. No other joint in the body has the same inflammatory reaction that the TM joint has. So to compare it to a knee is wrong. It suffers an inflammatory reaction that is unique. Well, what's to say that the right joint doesn't get more damage than the left joint? I mean, the body isn't going to disperse things equally all the time. So there can be a unilateral problem as well. So anyway, I think that there are so many little subsets that you're back to your original question. Why do you argue so much? Because you're just seeing different people. I have a background with Mark and Jim, and I respect everything they do, and I use it all the time. I image constantly. You know, I am not as aggressive as he would be, but I get imaging a ton for a restorative dentist. I believe in it, but remember with the first question you asked me, which is, like, how did you get into it and all that? It's because I don't accept what people say. When things don't make sense to me, I read more and I investigate more. And so that's where I am with it. And I think there's so many little offshoots. I think that's why people get in arguments.
Yeah. Well, and I think there's sort of this need to like kind of like have like almost like a cult leader or whatever that like you said, maybe like the dogma is like so and so said this. So that's all we know. That's all we're going to accept that. But the fact of the matter is that what we're learning and discovering through literature is different and it's changing. And so by being humble and curious and, looking at maybe a new concept and saying like, okay, well, I'm willing to explore that. I think that's part of my practice is like I'm a CE junkie. I'm a lifelong learner. Like I want to keep always be like pushing and looking to, all the colleagues around me to kind of continue to push me forward as well. But I definitely think there's been gaps in our dental education. And to me, it's exciting to be able to collaborate with, myofunctional therapists that are maybe PTs, SLPs. They have, a more collaborative experience and, they're going to be seeing things that maybe, the dentist that's coming in for like a 5-minute exam is not picking up on or not aware of.
The thing about myofunctional and SLP and all that group, and you said the right word, they have to collaborate with the dentist and with the ENT, but the dentist in particular, an orthodontist, if you were to get right down to the person that I think is probably the key. If they choose to try to fix the problem within the defect that they've been presented, they're not going to be as successful as if you can correct what do we say, the wax rim. If you can make the wax rim normal, then those people are incredibly successful. So I've had a myofunctional therapist in my office since 2012, maybe something like that. So I've got 2 right now in the office. So I'm a huge advocate of myofunctional therapists beyond the idea of tongue tie, because tongue tie is such a small piece of what they do. It's just a barrier to doing their job, right? But what I found and what is frustrating is they're just like, everyone else. They get a person in and start doing their thing rather than getting everyone involved and creating an overall plan. And I'll look at some, like I walk by and go, Kathy, what are you doing? Well, they were referred by so and so, and like, well, yeah, you saw though how narrow the arch is, right? Yeah, I know. I just can't. So we still have to do it as a team. A team is where they're just going to relapse. It's like chiropractic stuff. I believe in chiropractic stuff, but how come
You
I
have to
always had to have
reinforce
it over
it.
and over again?
Yeah, you have to reinforce it with postural education and fixing some of those, the dysfunction of the biomechanics of the system. Absolutely.
Yeah. So
Yeah.
Rockabato has been
Yes.
talking about physical therapy and
Yeah.
chiropractic stuff forever and ever and ever. But if
Mhm.
you look at the cases, they routinely relapse unless he works in conjunction with orthognathics, orthodontics, something else.
Yeah.
It's a bigger deal. And ours will relapse as well, just slower. If we
Yeah.
move the skeleton and the teeth, it's going to relapse. But the soft tissue just takes longer to mess up, right? So that's both are important. I'm still leading with the skeleton. Make the
Yeah.
skeleton normal first.
Yeah. Well, and then you think about, how often the cervical spine is maybe injured in, let's say, like a motor vehicle accident. I've been in three and they've been atrocious, and
Note to self: don't ride with Tiffany anywhere.
they weren't all my fault, but so as a PT, you're very, well trained in treating the cervical spine dysfunction, and being able to take imaging and put that together with your comprehensive plan. But oftentimes I feel like the TM joints are not adequately, imaged or evaluated at the same time. And, that's where it kind of goes back to, your comprehensive exam plus that modern imaging. I mean, like, of course, we have to be judicious with our imaging, but I mean, how often does a dentist know how to like palpate the neck or like, you know?
No, I mean, you're going to be better than I am. I would no. I would say no. I'm not good at it. I would throw in one other thing though into the mix, which is you're going from neck to imaging joints. But I'm telling you, if the joints are off, the maxilla's off.
Mhm.
And whether if you listen to Jim, he'll say if the mandible doesn't grow, the maxilla doesn't grow, which is true. But I'm going to tell you, if the maxilla doesn't grow, the mandible has to follow suit. It's not going to go into its normal position in any way, shape, or form. And so I think that the limitation of the team, that whole group of people looking at the mandible as being an important component, is you're not looking at the maxilla.
Mhm.
And so at the AES meeting a couple of years ago, I presented with Jim and Mark Piper, and the last question was from Whit Wilkerson, and he went through this very complex question describing about the pain and the jaw and the this and the that. And I went, there's your problem. You just spent 5 minutes asking a question and didn't mention a thing about the maxilla. And if you go fix a mandible to a deficient maxilla, they're still screwed.
Mhm.
They are. They can't breathe. They're going to be sympathetically active, which is where the pain response comes from. You've messed them up. You have to start by figuring out where the maxilla goes first, and then you fix the mandible to it,
Mhm.
not leaving the maxilla where it is and somehow repair this and then wiggle the teeth around. You've got to idealize the maxilla. So you ask, where did the airway stuff come from? That's where it came from. It came as taking a three-dimensional look at the maxilla, because that's where breathing and health comes from. But
Mhm.
more importantly, it's where aesthetics and function come from. It all has to start with the upper, just like you're setting a denture. You always set the maxillary denture first, and then you work the mandible to it.
Mhm.
And while at the very beginning, I was doing a ton of screening and talking about apnea and all, like let's get involved with your physician. I don't do any of that hardly anymore.
Mhm.
What I talk to them about is that there's a possibility if I make your maxilla wider or forward, whatever it happens to be, that you're going to feel better, breathe better, sleep better.
Mhm.
You probably will, because everyone tends to. I don't know how much, could be a little or a lot. But what I do know is your smile will be better and your function will be better when we're done. And I'm just a dentist. So that's
Yeah.
all I do is make your teeth go where they're supposed to go.
What do you think most general dentists get wrong about just putting in a mandibular advancement device for sleep?
They're not fixing anyone.
Yeah.
They never fix anyone. Patient continues to get worse. They also miss the idea that all day long, once the appliance is out, the patient's sick. The heart rate variability studies done on patients with malocclusions show that they're incredibly unhealthy and compared to patients that are normal,
Yeah.
which means that they're just suffering all day long. So they're making their patient die slower.
Yeah.
I would just prefer to make them normal and then let the body do what it needs to do. Now, they still may need an appliance in the end,
Mhm.
maybe. But I mean, my job as a dentist is to try to put the teeth in the position they're supposed to be and make sure they stay healthy and function well. And what we've been limited by is the bone.
Mhm.
If we don't get involved in it early enough, which is what we really should be doing, is seeing these kids at 2, 3, 4 and making changes. But if we don't do that and we now see him as an adult in pain with joint issues, let's say, you have to reverse time.
Yeah.
Well, you wouldn't in a little bitty kid with a crowded arch, I shouldn't say you wouldn't try to work to that crowding because we do, but most of the time you at least, if it's bad enough, the thought is let's expand, let's protract, let's do things to try to normalize things. But with adults, we don't ever consider normalization. And maybe some of it is semantic because we say make, like everyone would say, make the box bigger, make the mouth bigger, make the oral cavity bigger. And it's not. We're not making it bigger, we're making it normal. So to make it bigger implies we're making it abnormal outside of, the confines of what is normal, and it's not. It is abnormal right now. Make it normal. Just make it normal. That's all you got to do. Make things normal. And the teeth fit and the bite works. And if it doesn't work, look at the joint and say, okay, I got the maxilla normal. Why can't I get the mandible normal? And the answer, if you can't, honestly, if you can't get the mandible normal, it's the joint. It's most common answer that you're going to have. And then you get to play the game. Do I want to repair the joint?
Or let it burn
And then,
out.
or do I want to repair? Well, do I want to repair the joint? Do I want to take a chance on the joint and manage the joint? Right? Do I want to do BSSO and just manage the joint, or people don't die of class 2ism, so sometimes you just live with it. But yeah, I mean, I don't know. I just think it's cool. I think everything about where we're at right now in dentistry and switching from,
It's super
because
exciting.
I've gotten to see the evolution, right? I was on the tail end of nathology and the big Panky Man Schuyler and Dawson, and I was on the tail end as that started to wane, and now picking up with a new biologic perspective is really pretty cool, and being able to be around the people like Jim and Mark and you and all the people that are sort of leading this charge from a mandibular, a mandible standpoint. I have a good understanding of it, not your level, but I have a really pretty darn good understanding of the mandible and things that can be done for it and to it. But the part I add to the equation is the maxilla and all the changes that we can make in the maxilla, and then pair the mandible to it so we get beauty and function and health.
Absolutely. Yeah, absolutely. And now you have kind of gone through a personal experience of some of the things that you've
Ah,
tell us, just give us a little
Cliff
glimpse
Notes
into what
version
that
is
was
when I wrote the bruxism triad and started learning about Airway. I looked at my son,
like.
who had all kinds of different problems with sleep and breathing, and in the end of that, it took me 3 surgeries and a bunch of ortho, and I still haven't gotten him better. He's 19 now. His name is Jake, and so he's got attention deficit, dyslexia, dyscalculia, dysgraphia. He's got a little bit of like all these challenges that I don't think I could have made them go away, but I would have made them a lot better than what they are. He would have been better than what he is. So he's second year at college, and it's very challenging for him.
Old
Things
was he when you started to
when
recognize, how old was he?
four,
Okay. Yeah.
four, 4 or 5, I knew something was going on. By 6, he had had 3 surgeries. At 7, he was doing ortho,
Hmm.
and it's like I did it all wrong. I mean, everything I did was wrong. You know, in hindsight, it was crazy. But anyway, in my lectures, I always ask people to, who's your Jake? And I always remind them to look at themselves because, in fact, they could be a Jake, and I was. So I was right around 50, and I went in for a sleep study, and I had apnea. I had an AHI of 9. And I wore for a couple of years, I want to change diet and exercise, and I wore a mandibular advancement appliance. And I woke up one morning having worn it, and I didn't have to protrude. I needed to protrude about 1.5 millimeters, so it wasn't much. And I woke up and went, I mean, it smells, it's just nasty. I mean, it's like, I don't want to, for the rest of my life, I mean, I could be living another 35 years, or honest to God, I'm going to wear this stinky piece of plastic for that amount of time. That doesn't make sense. And then I remember looking at it from the side and going, if I could turn myself into this, I wouldn't have to wear it. So that's where it all began. And yeah, I went through surgically facilitated orthodontic therapy and expanded my arches and created enough room in my mouth and did some restorations. I had veneers on my teeth to kind of hide the discrepancy. Like my arches were really narrow and we just warped the veneers to kind of give the illusion of a decent smile. And so then redid the veneers. My HI's one.
Who
And I
did
can
you
drink.
trust
I
for
can
your
drink.
SFOT? Was it Dr. Manzanares or who did your?
No, George's a good friend, but I went to, so the person at the time that was probably doing more sophisticated SFOT than anyone was Rick Robley in Arkansas, and
Okay.
Mike Curry was his surgeon there. So we did it with Invisalign, changed trays out every couple of days. I actually had two surgeries. The wrap effect lasts about 3 months, 3 to 4 months, and at the end of that, we'd just gotten a bunch of tipping, and so we did it again so I could get the torque. Two surgeries, I took 3 Advil total.
Wow.
So it's not that uncomfortable. It's a lot of swelling, like pressure from swelling, but not pain. Yeah, so it was great for me. I would do it differently today. There are new tools that are available, different things that I would choose. So my mouth would be done differently today, and there would be other advantages to doing it differently. But I mean, I'm happy that I did something, and I know that all day long I'm way better off, and you won't be able to quantify it, but I know I'll live longer because of it, and
Absolutely.
I'll live better because I did it. And if I had done it when I was, you know, 20 or 30 or even in my teens, or I mean, if you look at me as a kid, I had my mouth open constantly, so I needed my tonsils and adenoids out when I was little, but when
Yeah.
that never happened.
Yeah. Yeah. Well, talk to me a little bit about mentorship because I'm really excited. I know you have some Rouse residents. I know you've got some people that you're working with,
Yeah.
and you said on your podcast you're really interested in, elevating especially females and maybe like, some minority dentists that are coming out of school. They're overwhelmed, maybe they're looking for someone who has your expertise.
There was a lecture I gave for the Seattle Study Club meeting in, I think it was 2017, and the title of the meeting was Legacy, and it made me start to think about what would be my legacy. And I had already developed a bunch of the Airway stuff, and Bill and I had done the global diagnosis deal, and it's been cool. I've done a lot of stuff. I wrote chapters and textbooks on veneers and anterior ceramic crowns, and I've developed implants, and I mean, I've done all kinds of cool stuff. And so I've had a really neat career, and I started thinking about the legacy of it and what I would leave behind. And I had always liked to mentor and mainly like go teach residents at the school. I love doing that. And Bill Robbins had me involved with that early. Bob Cronin at the school in the Prost department kept me on after I graduated, and I was teaching residents. But it was it wasn't a thoughtful or a thought out sort of focus. It was just you kind of showed up and did stuff. And then if any of them happened to want to come and ask you more questions, they could do that as well. So I wanted it to be more meaningful, more thoughtful, more directed. And so I sat down, actually, I was working with Greg Kinzer at the time and said, we need to figure out a way to teach young, really good dentists how to present so that we can make the next and help them so they don't have to go through all the bumps that we did, and then get them opportunities to speak and all the rest. So the idea had been out there for a long time of doing it, and I never could establish sort of a way of making it happen until a few years back when Spear finally is like focused on, okay, we really need this to happen. And so I was already excited about the idea and already had made a bunch of notes on how to do it, and I started putting together that for my Airway course. So my Airway course at Spear, the mentors that come in and help the people with all their hands on became the core of what they call themselves Rouse residents. And that core will actually, I work with them and putting together presentations that they give to the course during the course. And so they'll send me ideas, we'll edit it, we get together and work on it. They come back, they present again, we do it a few times, then they present it at the meeting. And then what we're going to do is build on that so that we take a small presentation and keep getting it bigger and bigger. And I'm kind of passionate about this, so I might talk a little bit. So
No,
I'm
it's awesome. I mean, I'm like, how can I be a Rouse resident?
sorry.
I want to be mentored.
That's where it kind of began. Well, it, I mean, all these people are really talented dentists, and they all are doing things that, I mean, some of them are doing stuff that I'm like, wow, that's amazing. Stuff I can't do. Now, I always tell them, someday you'll be as good as me. Not yet, but someday you will. But
Yeah.
to be, I mean, perfectly honest, a lot of them are better at me at certain things, and I'll never tell them that. But it's like your kids. But they're really good. And now to be able to take that really good dentistry and be able to put it in a clean package where they can teach people and learn how to actually not just talk at people, but educate people, it's really cool to watch. So, this coming year at the American Academy of Restorative Dentistry, which is one of the sort of, I would suggest probably the premier meeting in all of dentistry, I'm the president this year. And so I made a decision. The program takes 2 years to develop. And I made a decision a couple of years ago that my year of being president, the program would include as many young dentists as we could on stage, as many female dentists as we could, and as many minority dentists as we could. And my charge to the people running my program was, this is the best meeting in the world. It has to still be the best meeting in the world. If we can make it the best meeting in the world and yet still allow more diversity on the stage, that's what I want to do. Because half of the 600 people, or a little more than half, are guests. And our guests do not look like our members at all. They are way more diverse than our members are. Now, our membership is getting more and more diverse, but not nearly like the guests. So my vision was, I want to put people on the stage that look like our guests. So that if I'm a young, I'm 30-year-old dentist, 35-year-old dentist, early in my career, but really have aspirations to be great, I can look up on the stage and see somebody that's 35 and has already reached a level that allows them to speak to this world-class meeting. And we did it. So there are 6 speakers on Saturday, of which 3 of them, half of them, are going to be females. And the other 3 are actually like Brazilian. And I mean, they're not, there's no old white guys going to be on the stage that day.
How did you know I rail against the old white men? No, not really. I have lots
So,
of old white men I love.
so that's day 2. There are almost half of the speakers day 2. No, over half of the speakers day 2 fit that criteria as well. So it's young, it's females, it's minorities. It's crazy what a great, and the meeting is going to be phenomenal, phenomenal. Now, so I'm really happy about that. A few of my Rouse residents, 2 of them are actually, well, Melissa, but Siebert is presenting this year, and so it's going to be great. I mean, the quality of the program is going to be wonderful, but I'm so thankful that we're able to put together a program like that. Now, I will say it's really hard to do that, and so what I'm hoping is that if we place these people in a position to be seen by the best, that will spur new people to want to be the best. That's my hope, because the bench is pretty shallow in depth for quality, young is easy to understand, but women and minorities, pretty shallow. So we need to work harder at promoting that, and that's part of what I've been doing is trying to make that happen. It's been
Yeah.
fun.
Cool. Well, and I mean that's really what my vision is for TMD Collective is to really become kind of like an educational powerhouse that is reaching out to, like I said, a lot of different types of people, myofunctional therapists, bringing in those PTs, those, dental hygienists but again, I feel like the general dentist, we're perfectly positioned to drive this discussion forward because we can order imaging, we can understand how to do a comprehensive diagnosis, we can bring these people in and really lead and collaborate because, I mean, I've just been so blessed to, work with people like Dr. Drew McDonald and, Dr. Brian Shaw. And I love talking with other specialists. They get a little different perspective. But like I said, I love bringing in kind of that PT perspective and Pilates too, because you got to reinforce those postural changes. And like you said, you can't just chiropractically manipulate or osteopathically manipulate the dysfunction. You've got to figure out what is causing it and how can we, make that better.
The part you're bringing to the forefront, and hopefully, because I heard it, and hopefully you reinforce it in the future, is that what you do is lead. You put together the team, you work with them, but everything you just said was you were taking a leadership role in developing that plan. And that's what too many general practitioners shy away from. And they simply will fill out a referral form and check boxes, please evaluate,
Mm-hmm.
and they don't lead. And so, too many cases are, and this is of all types, not just joint cases. Too many cases get a box checked, and it ends up in an orthodontist's office or a surgeon's office with no guidance from the general practitioner telling them, here's what I want you to do. Here's what I've seen. I did an exam. I found this. Here's what I think is going on. What do you think? What do you think we should do? Because I'm kind of thinking this. So throwing out ideas of preliminary plans, creating guidance, creating teamwork, that doesn't happen if you just send the case over, please evaluate. Now the orthodontist has got to come up with how to restore the teeth, where they ought to be at the end, how to deal with the joint. Not going to happen. That's the wrong approach. So everything you just said is ideal because you were focused on how you were going to be the leader of this whole thing and bring in all the great, all these other wonderful people to assist you in your plan. So hopefully that continues to be a focus of your webcast, that how can we, the restorative dentists, be the leaders, because
The
you
lead.
can. That's what you have to have
Yeah.
in order for this to work right. You have to have that leader, and that's why when Jim was teaching the Piper McKee Study Club, it was all about restorative dentists need to do that. You need to do this kind of exam, and you need to get this kind of imaging, and you need to do. I mean, he's a restorative dentist leading the team.
Mm-hmm.
Piper came in just to confirm and do a thing, and Lisa McKee would do the orthodontics, but Jim was the leader in that team. That's the key. And it's the same with Airway. Airway is just, it's just treatment planning. And it's comprehensive, complex treatment planning that involves an interdisciplinary team, and it has to have a leader. The leader needs to be the restorative dentist every time.
Tell us a little bit about what is coming down the pipeline for you, Dr. Rouse. Like, what exciting things do you have that you'd like to maybe share or tell our listeners where they can find you?
I guess the excitement is coming up next February at the Restorative Academy meeting, and my
Okay.
residents are going to be presenting. But the Spear Education is where I do most of the teaching. I'm only doing a handful of different study clubs around the country anymore. I'm out almost exclusively at Spear, and I'm teaching two main areas. Lots of different. We're teaching worn dentition and airway, but for somebody just sort of hearing about me for the first time, there are two main courses that I'm in. One is the Airway workshop. Airway Workshop is myself and Jameson Spencer. And
Mhm.
so for 2 days, I talk about airway, which to me is the anatomy and how we can evaluate the anatomy and deal with the anatomy early on. And then if you miss it, how to deal with it later on. And then the last part is you're going to eventually, there are going to be people that need mandibular advancement appliances, and we need to be able to do it in a fee-for-service environment rather than having to fight all these medical billing and all that crap. So
Mhm.
we teach it from a fee-for-service perspective of how to make a mandibular advancement appliance, and then he teaches about which one would be appropriate, how to manage it, all that kind of thing. So that's Airway. I always say Airway, but now it's called Airway and Sleep. The other one is facially generated treatment planning, which is how to treatment plan patients. And that's where do the teeth go and how do you put them in the right location and how do you know how to plan these cases out. And it used to be that we thought of it as a way of doing full mouth rehabilitations because that's what Spear's always been known for is, oh, if you want to know how to do the big cases, that's where you go. But if you think about it, the reason it got that reputation was that it was an idea developed in the past. Frank first talked about it in 1986 in Chicago at the Fixed meeting. Crown and Bridge is what it used to be called, Crown and Bridge Study Club or something like that. Well, in 1986, he didn't have an orthodontist that could intrude teeth or do some of the fancy things that we can do today. So the only way to deal with overjet issues was to open the vertical dimension for the most part, or do a bunch of crowns, right? And so it got the reputation as being full mouth rehabilitation because it was the only way of dealing with it, those types of problems. Today we've got all these orthodontic solutions. So while we'll teach you how to think through a full mouth rehabilitation, where the teeth belong, how they function against each other, structural and biologic issues, really, when we're teaching you to think for all the cases that come into practice, not just, you're not, don't think of it as the place I'm going to learn rehabs. Think of it as the place I'm going to learn to do better dentistry of all types. That's what we do at Spear, and facially generated treatment planning is where it begins. So those are the two ones I'm excited about.
Love it. Love it. Well, next time you're in Seattle, you got to hit me up. We'll take you out wake surfing, come in
Oh, sweet.
August.
Yeah, I love wakeboarding, so I've never done the surfing version. So
Oh yeah, yeah. It doesn't
cool.
hurt quite as much when you fall, I mean, you can
Yeah.
still take some pretty good headers. It was such a pleasure to have you again. Thank you. I'm so honored to have you on the show today. Thank you for your time. I mean, I feel like I could talk to you for another hour, but I just thank you again for being willing to come onto my little humble podcast. So
Well, no, that was a blast, and we were talking a little bit, and I told you that I do follow what you do, and I do it as part of this mentoring idea. Is I am always on the lookout for young, talented dentists in particular, and then you throw in that you have a female perspective and a mom and all those things, which are challenges that I didn't have to face, and that adds to the equation. I think it is even more powerful, all the neat things you're doing. So I'm glad I could do it. Hope we continue a relationship, and maybe we'll get you in the Rouse residence again.
absolutely. Absolutely. Sign me up. All right. And there you have it. Another fantastic episode of Jaw Talk with Dr. Tiffany. A big thank you to our guest today, Dr. Jeff Rouse, for sharing his incredible story with us. So thank you for joining us. And if you could just do us a favor, if you could give us a 5-star review to support the show, it really helps other people discover the podcast and helps us bring quality content to the show. And if you would like to consider being a subscriber, we do have, for as little as $3 a month, you can be a subscriber to the show. And that really helps us build our podcast network, keeps those pesky ads from coming into the podcast, and just really helps support the show. Thank you for joining us. Stay tuned for more exciting episodes of Jaw Talk with Dr. Tiffany as we continue to bring you more quality content in the world of Airway plus Myo plus TMJ. Until next time, stay humble, stay curious.